to this episode of Compliance Deconstructed. I am joined by Lorie Davis and Elvan Baker. And today's topic, actually, we're super excited about today's topic. I mean, to be fair, it's rare that we're not excited about a podcast episode, but this is an interesting topic. And this is carrying on from a conversation Elvan, Lorie, and I had in a previous podcast, and we've decided to explore it a bit further. We're looking at clinician education and whether or not there are some gaps in that education in terms of, the education that clinicians get is great, the clinical and academic aspects of it. But there's a lot about the reality of working in a clinical environment that medical and clinical and nursing education doesn't always quite cover. So we were thinking along the lines of, there really isn't much training or education around a business environment or the compliance or regulatory environment or education around the administrative load that's involved in working in the healthcare space as a clinician. And Lorie and I and Elvan wanted to do a little bit of a deeper dive on those issues and the impact then on compliance and on patients and on the clinicians themselves. So that's what we're going to talk a little bit about today. So Elvan, if we kick off, I mean, what do you think are the biggest maybe deficits, if you will, in clinical education at the moment?
Unfortunately, what I used to think little, it's a lot. I used to think that we could summarize it by saying that we are too stuck on theoretical formal education and missing the true real life hands-on experience. But over the course of years, I have changed my stance. I'm a clinician trained in the United States. This country has one of the best higher formal education for clinical degrees, where somebody comes out of the school and they are a tradesman and ready to rock and roll. I want to add that. It's very important that I add that because I value the education that we provide in this country, bar none, to anywhere else. However, over the course of years, as I have pivoted from bedside to non-clinical to corporate roles, especially roles in compliance, and started mentoring other clinicians who are trying to pivot, I see a huge gap, and it's not just in one little area, but in multitude of areas. You touched on some of them. We definitely are missing the hands-on experience. I know the comeback is going to be, well, we require a lot of clinical hours. Yes, those clinical hours usually happen under the mentorship and the supervisorship of another therapist. So you're heavily influenced by that specific setting and that specific clinician's preferences, experiences, perspectives, so on and so forth. So that varies greatly. We are trained as single standing individuals, even though we come out into the field, and we rarely operate as a silo. What we do, how well we achieve what we do, the effect that we have on patients are highly influenced by the environment that we're in. And by environment, I mean by different colleagues, not just other clinicians, but other entities. People like you and I and Lorie, who give you a call in the middle of the day and say, I see something, what's going on here, right? I mean, workload that's affected by it. We genuinely have a gross missing link in teaching and practicing non-clinical skills. And I would divide that into business skills, because even if you don't own your own business, you need to understand business, because in the United States, healthcare is for profit. Very few and far in between entities utilize it as a nonprofit, and you'll get to have the luxury of that, and you'll have the burdens of that. But not just a business, but we have a huge gap in teaching the compliance and regulatory issues that comes with the fact that This is a highly regulated environment. Your actions, your capabilities will be tried and tried again by what you are told you can or cannot do. So there's a huge missing link there. We are having also a hard time linking. We think, other than acting like we are going to be a silo operating coming out of the school, we're also not taught that individuals that come to you for your specialty will be coming to you for that specialty alone, which also doesn't happen. When I go to my physician and I say I have a neck ache, it may be a variety of things that have nothing to do with my physiology in that moment, right? So that clinician really needs to understand that a person and person's specific diagnostic needs may or may not have to do with what it's presented to you in that moment, because a person is it's a whole person picture, right? What my needs are even affected today by today I'm feeling really good because I'm doing something that I desperately love, recording with you ladies. That's going to up my psyche today. I mean, this is the reality, versus tomorrow, probably at around this time, I'm going to be stressed out of my mind. So it's going to be different when I show up to the clinician. So we really are missing those parts. The worst part that we're missing, worst part that we're missing, and I'm going to shut up after this, is that we are not telling the clinicians the truth, what is out there.
Okay.
Few ways. We are not telling them how it's going to be in real life, what their daily flow is going to be, to get them prepared so that they can prevent burnout. We're not doing that because we're not telling them about the truth, what it's going to look like. We're also not preventing the wrong players from entering the market. Not everybody is fit to be a clinician. Just because you want to you have a great idea in medicine doesn't mean you should be a clinician and you should own a license. Just because you want to help patients, it's not good enough of a reason. So when we have these people who really don't understand what they're getting into, but they get into it, and after $200,000 in student loan debt, they feel obligated to go through it. Now we have compliance problems because it's not intuitive, it's not natural. So mistakes happen when burnout is in place. That's when the biggest mistakes happen. That's what I found. And by the time us, the compliance individuals, get into the conversation with the said clinician, it's almost too late. They're already burnt out. They already made a mistake that might end a career or hurt a patient. Like, it's just we're not even we get into the picture entirely too late as a compliance individual. That's my experience so far. Have
Or
I
they might
covered
not
everything?
have the knowledge. Well, there's a
Correct.
lot there. You've actually covered, I mean, you've touched on the surface,
Mm-hmm.
right? And what we're going to do is dive a little bit
Mm-hmm.
deeper, because it seems to me there's a lot there that you've just said, and it's pretty heavy. And there's a lot more going on under the surface. And it's not just about burnout, but it's about a lack of education, and that leading to, compliance issues, patient safety issues, deficits in quality. And it's not
Mm-hmm.
necessarily the clinician being irresponsible or incompetent.
No,
That's not it. That's not
no,
what's going on. That's not what the episode is about. But it's
no.
generally about the system and the education, and whether,
Mm-hmm.
as a system, we provide our clinicians with enough support to enable
Mm-hmm.
them to make the decisions and the choices that
Mm-hmm.
they need to be particularly effective and lead a successful career in healthcare. And successful can be just enjoying the experience of being
Mm-hmm.
a clinician and not burning out, that, or not being sued. For others, that could be it, or feeling that they can serve their patients, well, and that they feel confident every day. But let's explore a little bit
Mm-hmm.
more. First of all, Lorie, do you have anything to add?
So I just want to say, Elvan, everything you said was spot on and amazing. I read several articles from physicians
Mm-hmm.
themselves saying I was woefully underprepared to go serve patients and understand the complexities of running my own practice, working within a practice of multiple physicians.
Mhm.
I didn't understand everything, and asking for the curriculums to change, continue to give us all that direct clinical
Mhm.
expertise and
Mhm.
knowledge, but let's start layering in understanding things like the Affordable Health Care Act.
Mhm.
That is something that was cited over and over in every article I read that said, we don't understand this, let alone Medicare, Medicare Advantage, traditional Medicare versus Medicare Advantage. They didn't understand that. And then CHIP, what's CHIP?
Oh.
What's Medicaid? Medicaid and CHIP were cited as two government programs that they understood the least. Everybody seemed to generally sort of think they understood commercial. So I think what you're saying, and that can add to that burnout, not just
Mhm.
practicing medicine, but all of the business implications and having to think about what's a prior authorization, what's a pre-certification, what's
Why
a
do I need to do that?
pre-approval. Yeah, why does that
Can I
matter?
cut the corner?
Yeah, what's a marketplace? Like, I don't know. I know
Mhm.
how to treat my patient because I've got excellent clinical
Mhm.
knowledge, but I don't know how to shoehorn that into whatever line of business that my patient has as their insurance coverage. So
Mhm.
I think what you said is spot on.
Yeah, and then I think we find ourselves, I'm sorry, Jess, I jumped in right on top. I know
You're
you were going to
good.
say
You're
something, but I
good.
think this really ties in with what Lori's saying, because then we find ourselves in a situation where somebody's got to teach these clinicians, right? That's not knowing is not an option. Fine. Then who's going to teach you? Possibly the company that you work for. Even though the regulation states very clearly that you're the license holder, you are personally responsible for knowing it, we leave it up to the companies, those people who may employ us as the compliance individuals, to do this teaching. There's nothing wrong with that, and that's beautiful if your company is, again, well equipped to do so. But if not, you're at the mercy of their interpretation. Ta-da-da! Yet again, it becomes this difficult to get out cycle. The companies, it's their job to protect themselves and protect the patients, therefore. So they do what they need to do within the resources that they have, even though the clinician is supposed to know the totality of it. Yet another, it creates another gap. I thought this last night. I'm going to say this. I may be saying this too early in the episode, but I'm going to say this. I was thinking, Lorie, what do you think? So, how do we integrate this into the formal education? We can say a certain percentage of your curriculum needs to be XYZ. All of those, we can do that. I think that's the easy part of it. But how about we pick, and I know this is going to sound, oh, here comes the haters. This may be a little bit wrong, but how about we pick the educators, the professors out of a pool of people who have at least a decade in hands-on practice? What will that mean? 2.5 administrations they will have to go through to see how regulation laws affect their practice and the population and the specialty that they're serving. And I bet that will influence the theoretical formal education that they're providing to the next generation.
Well, there
Yeah,
are many ways of providing education, right? You could
Mhm.
also pull people from health plans. You could pull
Oh, yeah.
people from who could speak about Medicaid programs or Medicare, and you
Mhm.
could do
Mhm.
seminars, specialist seminars or whatever.
Mhm.
There are many ways of
Mhm.
providing that education. I agree with you. I think that's a great benefit. On the other hand, you risk pulling clinicians out of the field. So there are all kinds of pros and cons.
Mhm.
I'm sorry, Lorie, go for it.
Go ahead.
no, I was going to say something similar in that I like what Elvan's proposing in theory. I think the reality of that is we've already got, if I think about certain specialties, we already have a network shortage. Like, coming up with that buzzword of network adequacy is challenging given the geographic location of some of these
Mhm.
providers. I,
Correct.
I but I like the idea. For me, it's how am I a practitioner at a rural health clinic or a school-based clinic or something like that? When I went to college, they didn't have that class, right? They didn't have FQHC,
Oh yeah.
RHC, or SBC 101. Like that didn't exist. But I think that's a reality of where people are practicing. In Medicaid, I don't think they had an EVV 101, an electronic visit verification, because for most practitioners, that act didn't exist when they went to school. So I think we need to think about that. But to Jessica's point, I think it needs to be a combination, and largely what I've read, and Elvan, you can correct me if you disagree, but in the US, they have largely said, "Hey, we're gonna prepare you as an excellent clinician, and then we're gonna expect you to use your continuing education credits that you need to get to go get this kind of hands-on how to bill appropriately, what codes to use, how many clinicians," to your point, you show up with a neck ache. I'm a primary care physician, I'm a PCP, so I'm gonna do what I think is best for you, or I'm gonna refer you to a specialist, and then I'm gonna bill. I'm looking at hopefully having someone in my office, even if it's just one person that knows the coding, to tell me what that code is, essentially shoehorning it in. Is that the right thing? I don't know. I think it doesn't take into account that as a PCP, there's certain codes I can bill and certain codes I can't bill. As a specialist, my specialty allows me to bill certain codes, and, and then we start getting into putting it back to compliance, fraud, waste, and abuse, because I've coded incorrectly. Or if I'm supposed to code for 15 minutes or 30 minutes or an hour and I use the wrong code, oops, how does that all work?
Or
Right?
how
And
about
that's
charting and
Oh
documentation
yes,
yeah.
for those
yes,
codes,
yes,
I
yes,
mean,
right?
may I just
exactly.
say, looking back, I'm thinking about the assignments that we would have about case study and charting. Here we are made to write 4-page single space, kill me now. And you get into the field with today's EMRs, 3 buttons. Click, 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 click. It's all documented. Why did I
Yeah.
spend all that time? And then, exactly to your point, Lorie, but when I got into the field, we received zero education on coding, ethics of coding, fraud ways.
Mhm.
We did not. Neither did my spouse, who did a doctorate degree in occupational therapy. And
Mhm.
yesterday, I was talking with my colleagues within my department who are also therapists. They did not either. Yesterday, I kindly explained what a BAA is.
Mm.
We are a vendor
Yeah.
to therapy companies. I mean, it's
Yeah.
and nobody receives this education. So then what happens? Your first place of employment or your clinical rotation place becomes the place that teaches you this. That's where the lines get blurred. Is this a business practice for them that you bill this or that? Or is this a regulatory piece of information? Lines blur. 10 years later, when we get a fraud case, that's when the clinician says, that's what I've always been told.
Yeah.
But
And you
is
simply have to say
there
who.
Mhm.
is there, going
Mhm.
back to what Lorie said, and I wonder about this because I know the three of us take our jobs seriously. We're very interested in the field. We're interested in being the best that we can be. And we've all taken a lot of ownership in developing ourselves, including this podcast, right? That was part of our own personal and professional development. And we did it because we wanted to, right? No one forced us to do it. That's fine. But I do wonder, going back to a point Lorie made around continuing professional development, is there a responsibility for clinicians to get some of this training for themselves? Because that's something that's puzzled me. I feel compelled as a compliance professional to go out and continue my professional development, keep up to speed. what are our clinicians? Well, maybe, it's unfair to say clinicians aren't doing that, but they're probably focusing on the clinical aspects of the care that they provide, and they're probably keeping up in those areas. But maybe what they're not realizing is the importance of doing continuing professional development in compliance and the regulatory space and making sure they're keeping up. But I'll also throw in that I think it can be really complex. I mean, that's not the complexity of the healthcare space in the US shouldn't prevent anybody from going out and learning and understanding the system. That's not a good enough excuse. But I'll also say I do feel that there's some responsibility on maybe insurance companies or health plans when they contract with clinicians to make sure that, or to try and offer some education around, for example, what is Medicare? What's traditional Medicare? What's Medicare Advantage? What does Medicaid look like for that state? And I say that because different health plans, Lorie, you're a big proponent of this, or you message this quite often. Every health plan is a bit different. Every state for Medicaid is a bit different. That's a lot for different clinicians to know, and not just clinicians, but healthcare organizations or companies or businesses that work across states. Is it their job to know? Yes, but actually there are other stakeholders in the environment that are probably also responsible for contributing to education. And I'm not confident that they do, or some actors are better at it than
Yeah.
others. And then I think of really small practices. Some of my clients are like 1, 2, 3-person shows. Like, how do they find the resource and the time? I'm playing devil's advocate. I don't think any of this is an excuse, don't get me wrong, but I'm playing devil's advocate. How do some of those smaller organizations that don't have the resources or necessarily the time tap into the education that they need? And oftentimes they're the ones who need it the most.
Yeah.
They can't
And
get it.
I go back to this frequently, but I also think it depends on the type of insurance. So, for example, in Pennsylvania Medicaid, there is a role that is required of all health plans called the provider claims educator. And that person's job is to go out to providers and make sure that they understand how to bill appropriately. Not every state has that role required. It will vary widely, Jessica, based on what you said. But I can say in Pennsylvania, that is a required role for Medicaid. It's written into the state agreement that every MCO signs, and that person is required to provide a training curriculum, evidence that they've done that training with providers. And so if you go to any of the health plans in Pennsylvania and you look at their website, they are offering provider education on a recurring basis, whether it be in person or virtually. In West Virginia, they have provider panels that are done twice a year, and there's representation from the state and all of the MCOs that are in the state, and they each provide information. So there are efforts being done. But again, that's my experience in Medicaid, and that doesn't necessarily help all the other ones. But I do know in Medicare Advantage, they have a learning system where they're offering trainings for Medicare and Medicare Advantage, traditional Medicare and Medicare Advantage. Let me be clear, it's both. So there are things out there, and there is a professional networking app that has a blue symbol that I won't mention, but literally, if you go a search, you can find education being offered, but the onus is really on you to go sign up for it. I just saw one this morning that's being offered for professional coding, in the hopes of folks that want to get their professional coding certification, and there's webinars there. So practitioners and the support staff, they can go get that, but they really have to go look for it. It's not foisted upon them.
Not
That's
only
right.
that, like, you're going to do CEOs and not CEOs. What am I talking about? CEUs. And well, you're a clinician. Again, we're going back to that. you have a specialty and you're like, personally, when I take CEUs, I take about a very specific subject because I want to keep up my knowledge on that subject. I don't want to go around learning about coding. Like, and I mean, which part of the gap should the clinician fill? Their business skills, their regulatory knowledge, coding and documenting, clinical knowledge. If I am the
Yes.
patient, I want them to get better at treating me, not documenting about me. I mean,
Yeah.
I'm the patient. I'm
And
just looking from that perspective, right?
Elvan, you just hit the nerve that I have is making sure that patients understand what
Mm.
their insurance
Oh,
covers.
yes.
And that goes back to the compliance
Mhm.
of it all, right? Back in the day, we used to do service verification checks where we would pull claims and we would call members and say, "Hey, member, you went to see Dr. So and so and had this, did that actually happen?" Or not worded exactly like that. And it's hard, right? Because if members don't understand what they were treated for or how they were treated, can be somewhat problematic because now you're in fraud, waste, and abuse land, and the member just didn't understand what was done. So I think that's why it's so important that there is a broad understanding. I had conversations with some contacts yesterday, and I asked them in preparation for today, "Hey, when you go see the doctor,
Mm.
do you feel like your doctor understands that you have this kind of insurance and you can get this kind of treatment? Or do you think they understand? Do you understand what this means?" And the one I brought up is our favorite buzzword of prior authorization. I said, "Do you understand what a prior authorization is? It's a bunch of paperwork, and until I have that paperwork, I can't get my treatment." That's what one person said, and I was like, "Okay, well, yeah, but do you understand why it's in place?"
Mhm.
"No, no, no, I have no idea." So I think that from a compliance standpoint, education is power, and that's one of our 7 elements is education. So I think it's really important that clinicians and patients or members, if we're in the health plan world, have that knowledge to understand what is required for their insurance so that they get treated appropriately.
And you guys are really getting to the heart of this particular conversation, right? Because Elvon, we were talking one
Mhm.
day, it might have been in our prep session, and you really put it quite clearly. You gave an example. I mean, first of all, the heart of the conversation is why is it all this education that we're talking about, this non-clinical education, why is it so important? That was the thrust of this particular episode, what we want to get to. And I'd like to explore that a bit further, looking topic by topic. So, first of all, you raised a really good point. You gave an example of a privacy issue. And,
Mhm.
a lot of clinicians may know, they may even recognize a privacy HIPAA violation or a HIPAA breach. And they may know why they need to report. They might know that they need to report it.
Mhm.
But what they might not understand is the why and what's really going on. Do you mind talking about that example a little bit more?
Yes, recently, without giving too much information, I want to respect everybody's privacy. Talking about privacy. So we recently, and this is not the first time, this just happens to be yet another example in a conglomeration of an issue. Our clinicians are poorly educated on what PHI is, what constitutes a PHI, and how the regulation works, who it applies to, and who governs it. We have a gross undereducation on what those identifiers are and how the identifiers behave with each other, i.e., people always think, well, is it just the social security number? Is it just the name and last name? There is a context here, right? If where I am at, you say that Turkish girl with the last name Baker, within the 100-mile radius, I am the only one. Where I used to live in Denver, Colorado, probably not. I bet there are other Turkish ladies who with the last name Baker. So context matters. So first of all, there's a miseducation on not understanding that, how things interfere with each other. Meaning those identifiers are there as a starting point, but if any information can be utilized to lead to a person's personal information, personal healthcare information, it is considered a PHI. Okay, so those 12, 19, I don't know how many we have anymore, identifiers, they're just a starting point. There's a misunderstanding of that. And now from there on, clinicians have a misunderstanding of what breach may look like. They think it's always a bad actor doing something intentionally wrong, like identity theft. No, breach happens or may happen, or things may be considered breach, even if a good player unintentionally shares PHI with an unauthorized person. The person that they share may have authority over other PHI, but just not that specific one, right? And, Lorie talked about this in one of our episodes about, the water cooler conversation, and somebody overhears it. Yes, we all work in the same office. Yes, we all have access to PHI, but that specific PHI, those ears should not have heard it, right? So we have a misunderstanding of that one. And then
so that's where the lack of education around
100%.
what includes PHI
Correct.
becomes a risk.
Or what is a breach? Like, what is a breach? And everybody thinks it's not that big of a deal. It's not that big of a deal. But please, people understand that HIPAA laws are governed by OCR, Office of Civil Rights. There's a reason why they're not governed by, Health and Human Services, by CMS alone. Why? Somebody's information is their civil right.
Well, think about. Yep. Sorry. Go ahead.
Go ahead. No, go ahead. I mean,
I love her example, though.
It's great. I always think about. I have two thoughts. The first one is I grew up in a very small town. We had one doctor growing up. So something would happen at the doctor's office, and the receptionist, the person that would check you out, had a way of sharing information, and before long, everybody knew everybody's health condition. So there's a great example. But in that same scenario, think about when you're checking out as a patient, and the person that's checking you out has things all over their desk. And so it's very easy to see that patient Jane Doe needs to go get a CT, and patient John Brown needs to go get an MRI, and this patient needs to get this prescription, because it's all over the desk. They don't think about, oh, I need to flip this over so I'm not disclosing another patient's information. So it happens very innocently. I don't always think of it as something malicious. I think sometimes it's just your normal day. Like if you showed up to an office and people have things on their desk, to them, this is just what's on my desk. They don't think about, oh, I don't need Lorie to see what's happening to Jane and John and Bob and Mary. They don't think about it that way. And I think that's where the education needs to come in about why that's not a good thing. Lorie shouldn't know anything about any other patient.
Absolutely. And again, this is something I impress upon the people that I unfortunately have to have these conversation, is that please again know that this is governed by OCR. It's somebody else's civil right that you're stomping all over. Number one. Number two, HIPAA laws are one of the few things that clinicians can be held personally liable for. Meaning, this is very important. If I unintentionally misbill, which may or may not be considered fraud, but I work under a company, even though it's my license, I work under a company, it's likely that the regulatory body will go after the company. Why? Because I bill, but there's a coder in the background, medical biller. There's a lot of stop gaps that's supposed to watch my back too as a clinician. HIPAA is one of those things where that's not true. If OCR wants to go after you, your personal assets, They have a right. Why? Your actions cannot trump all over somebody else's civil rights. PHI is somebody's civil rights. I gave the example of this when we were discussing this conversation. The easiest way to think about this is that I had a hard day at work and I need to have a glass of wine. I just need just to cool my just and whatever my need is, that's my need. And it may be a legit need. And that's fantastically fine as long as I don't get behind the wheel. As soon as I get behind the wheel, I attempt to trump over somebody else's rights. I don't have that right. My right is not bigger than their right. Their right is bigger than my right. Therefore, I need to stay at home if I'm going to drink that wine and not get behind the wheel. PHI is the same thing. If your job needs you to handle PHI, you cannot do so by trumping all over somebody else's civil rights.
I love that example around civil rights. I'd never really heard that kind of the shaping of that conversation in that way. I'm like missing some words today, but I hadn't heard the conversation around HIPAA expressed in that particular way. And I genuinely think that's insightful, and I love it. That will change the way that I talk about HIPAA in my education and training. But the point is in saying that is that if you do not understand, if you don't have the education and you don't understand the context as a clinician as to what's going on, you then risk violating a law, and the consequences are actually quite severe. So that's one example of the consequences of lack of education. The other example I do want to go into, because it is so big and it is so important, there are two more I'd like to do deep dives on if time allows. But this idea of business context. So most of our healthcare, as both of you already acknowledged and said, well, in the US, these are businesses. You provide healthcare, it's a business. Why is it so important then to understand this business that you're getting into? So I think about things like, okay, you're running a business. What are the risks to your business? You, as a clinician, you can't just say, I'm going to start a business and I'm going to provide healthcare. None of us can do that. No business can do that, right? I run a healthcare compliance consultancy. I still need to know what laws and rules affect my particular business. Now, why is that? Because if I violate any of them, chances are I could be sued. Someone could get hurt. I could invite regulatory scrutiny. I could end up in jail. I could be audited by the IRS, right? I could lose everything that I've got. So I want to talk about, what does that business framework look like for a healthcare operation? And I think about things not just understanding HIPAA and where that's coming from, but I find that things like Stark Law and anti-kickback, and a lot of our clinicians do not know what that is. A lot of people work in the healthcare space. They don't know that those things even exist. So there's a real lack of education, and violating either of those has huge consequences for the business. Anyone agree, disagree?
Totally agree. Totally agree. Again, it starts out very innocently. Oh yeah, it's the holidays. It's this time of year, right? And the gift baskets start arriving, and the buckets of popcorn, and the
All the damn
lunches, and
popcorn,
all.
yes. The candy.
But it starts innocently, right? And they start taking these things, and then the prescription pads start getting written, and there is a correlation that has been found between the buckets of popcorn and the prescription pad.
Yeah.
So, but it starts very innocently. So, Jessica, I think you are spot on.
You know how much I love Johnson and Johnson, and using
There we
them
go.
as a case study. But no, but you just said prescription pads, and things start off very innocently with maybe pharmacy reps visiting. and clinicians not knowing to question or do a deeper dive or understanding the consequence. And also, there's a lot more to running a business. If you, I feel like if you're, oh, I don't even know how to start. I'm like tripping over myself. So, for example, I suppose if you don't understand billing and coding, how do you really understand how much revenue you might draw in? Or if you don't understand how your insurance companies work, how do you know what revenue you're going to generate? And that in turn comes into, okay, well, how do you know how many staff you need and what skill set those staff need? And if you don't have the right staff in the right place at the right time, you are going to make mistakes as a business, right? And also, what CRM should you use? What's important to look for, not in a CRM, but in an EHR, an EMR. I've been horrified. I've spoken to EHR companies where I go, hey, so how do you keep up to date when the codes change or the different rules change? And they go, oh, but that's not my problem. It's the clinician's problem. Well, the clinician doesn't know that. And I was doing, for example, an audit on a therapist's EHR, and I'm looking and I'm looking, and she's wondering, I keep getting rejections for this code. And I look up the code, and actually the code is obsolete. It's been obsolete and not in use for the last 10 years. So here's me. I think maybe I've missed something. So I always want to be really careful about how I advise. So I call a therapist colleague and I go, hey, what do you know about this code? Like, I'm a little puzzled. I looked
And
it
they
up and
go,
it
let
says
me
it's
call
not in
grandma.
use. Yeah. And they're like, no, you're completely right. But then I was really puzzled. I felt really badly for my client because I was like, I think you need to have a conversation with your EHR because I don't understand why they're still letting you bill for this or code. And clearly, there was a huge gap in information. She's not making the revenue. She's totally relying, and she's not alone. I've seen this many times. When I worked for an EHR company, truth was we worked very, very hard to keep the billing codes up to date. We really did. And not put our clients in a position where they might be non-compliant or they might get, claims that are rejected. But I was amazed at how many of our providers, our clients, never checked the codes for themselves. And they never did an audit
Correct.
of how their clinicians were billing. And when they got audited and there was a problem, some of them came to us and said, hey, this is your fault. And we were like, no, really, truly. We've even put in things into the CHR to prevent you from billing the wrong way. But there are limits. And if you don't have the education, and then the impact of an audit, like that costs money. It costs a lot of money. There's a lot of scrutiny. Someone may or may not go to jail. The amount of effort to respond to the audit and work with regulators and the time away from patient care, these are all part of a business. And Lorie, you put it brilliantly about the administration load as we were talking about prior authorizations. Like, if you don't understand as a business what the admin load is going to be working in the healthcare space, again, I come to how can you possibly resource that appropriately? How can you make sure that things like prior auths, how do you make sure you're understanding them for which insurance companies? What are the responsibilities? What information do you need to provide? And all the effort that then's put in when the process is wrong or there's not sufficient information, there's been a misunderstanding, all the effort and the time and the resources and the time away from patients to then correct those issues, or the burden gets put on patients to sit there and try to correct what's gone wrong. And it's almost an impossible situation. So as a business, and think about from a patient experience perspective, here you are, the clinician, you're doing your best to provide great clinical care. You get stymied by these administrative processes that you really didn't understand as a business in the first place. So you didn't take that into account in your business model. So now you get patients who are frustrated. They may have received best clinical care, but that's not their impression. So they're now walking away thinking, gee, that was frustrating. That really sucked. I've had to fight for healthcare and I don't understand, what am I doing with this practice, or what am I doing with this hospital, or what am I doing with this particular therapist? It makes for a bad patient experience, even when those patients have received great clinical care. So I could go on and on and on about, the importance of understanding, and not to mention the risk of fraud, waste, and abuse. If you don't understand that you are a business, the other bugbear that gets me is that people don't no, they're setting up a business in the healthcare space, and they don't understand, amongst many other things, they don't take into consideration, when we come back to HIPAA and privacy, that actually you could have great security to protect information within a practice or a hospital. That's fine. But what applies to any other business in the United States in terms of having a great security program isn't enough to meet the security requirements in a healthcare space. There are additional requirements and additional protections. And I get a lot of clients who say, yeah, I'm working with the security company. It's all good. And I'll speak to the security company and I'll say, hey, so do you know HIPAA? No, no. And I already know that because I'll have asked the client, hey, do you have a security risk assessment? And they'll go, what's that? And I think to myself, that's just like the number one thing in HIPAA. That's like the number one key important. And there are so many cases coming out of OCR about providers not having this one document. And then I know, and then I ask the question, well,
but again, the
support,
security company is going to be like, I didn't know. The company itself may say, I didn't know. And who does it fall on again? Clinicians.
That's right. And not understanding the context of the business and then inviting those risks. All I'm trying to show, like, I'm not saying that clinicians are in any way like irresponsible or incompetent. I'll go back to that. I think it's quite the opposite, right? But again, going to Lorie's wonderful phrase, I think it was Lorie, about non-clinical skills and how important those are to complement your medical or your clinical practice. And we're just trying to demonstrate why. Why are we saying this? We're not saying it because it's an opinion. We think, hey, we've seen the consequences. When you work in the compliance space, you see the consequences of clinicians not necessarily having those non-clinical skills. And unfortunately, it has some very real life consequences and impacts for everyone involved. Go ahead, Lorie.
I'm just agreeing with you. I'm agreeing with everything you're saying. That's all.
Fair enough. Am I missing anything, Elvan?
We're missing nothing and everything. This is a good conversation. We can have this. I mean, we could have broken this into the business ethics, because that's another part of it. This isn't just about, we have regulatory compliance because it's healthcare and we deal with patients, but there's business ethics here. There's business compliance. That's another part of this this is a tough one.
Well, here, can I throw this out there? Because another thing that sometimes, and I guess a lot of our listeners will be thinking, well, hold up. They've been going on and on about clinicians and non-clinical skills. And I thought this morning, it occurred to me, could someone throw this conversation back at us and say, well, hold up. You're compliance professionals. Do you get all the training in some of the clinical areas and how the healthcare system works and how, working in a practice actually works? I did have a client say that to me about something. And we were talking, I think, about clinical protocols and whether they were available. And I did know what I was talking about. She kind of took me by surprise and said, well, do you know how a practice works? And we really had to have that conversation where I said, well, actually, yes, but do you understand your responsibilities here and how to get, this information? And it was a great conversation in the end, but it was an interesting position to be in, with somebody saying to me, hey, but do you understand the clinical environment that I work in? And so I wonder, ladies, if you've come across that, where people are saying, hey, you might work in compliance, but do you know how to apply that compliance? How does it relate? It doesn't actually relate to what I do, does it? How could you possibly be able to make compliance relate to what I do? Do you get any of that?
I have, and I was fortunate that as part of my compliance training, I worked with the business owners
Mhm.
to understand the work they did, and so we could take what was in an agreement and crosswalk it to what they have to do, so it did apply to them. It did make sense. So they could ask questions and I could be like, "Oh, well, the contract says you have to do this or you shall do this." That must and shall you always hear about with agreements. Or in commercial, there's state regulations or federal regulations, and you could be like, well, this is what you have to do. This is what your burden is related to that. And really understand how it's going to impact them. And then where we needed to get with the regulators to push back and say, hold on, I understand what you're saying here, but this is what my business owners are telling me is an unfair or an undue burden.
Elvan, did you want to add to that?
No, I understood her message and we got to this point without the
I think all I'm saying is that, as compliance professionals, we live by those same rules. We've been talking about these non-clinical skills for
Mhm.
clinicians. And I just want to put it out there that for those of you who are wondering, like, we have to follow the same rules. We have to understand how a business operates, how a healthcare provider operates, how a particular team operates or a business unit within an organization. And we have to help them and we have to help figure out, well, how do the rules apply to that particular part of the business and the way that they operate? And that is fundamental to a
Mhm.
compliance professional. Otherwise, they're not going to be able to get buy-in. They won't be able to identify the appropriate risks. They won't be able to do their jobs unless they're adaptable enough, curious enough, partnership oriented enough to work with others to get the information they need and to understand that one clinical environment may be different from another and the impact on the healthcare, let's say economy or the healthcare, I don't know, organization might vary from one space to the next. So what's good for the goose is still good for the gander.
Mm. Nice.
All right.
Very well put.
I know. Okay, with that, I think we're running out of time, but it's been a wonderful exploration of, some of the areas where clinicians, tapping into the show might want to consider, the why. Why do we think these
Mhm.
non-clinical skills are so important?
Mhm.
We feel, in our opinion, that having some more insight around these non-clinical areas will help you to run a better business, will
Mhm.
hopefully make the practice, all that admin, a little less burdensome. Does
Mhm.
it take effort to get to know your space? Yes, of course it does. Is it worth the investment? We
Mhm.
think it is for
Mhm.
many
Because
reasons.
ultimately you excel in those, you're going to be able to provide better care, which is
Yes.
exactly what you want to do. But if you're struggling with those other areas, you're going to find yourself in a pretty bad cycle of trying to catch up at all times and feeling anxious about it. And that's going to lead to burnout. That really doesn't manifest itself in a premium patient care.
Or just making sure the success of your business, if you really are
Mhm.
you running your practice as a business, really the long-term success of your business really does depend on that additional education
Mhm.
and being able to identify where you might run up against particular challenges and issues. And it's not just regulatory, it is operational. How do you operationalize your
Mhm.
business most effectively? All right. And on that note, because we could go on for another hour, I suspect. So, on that note, let's tie things up. We'll say goodbye for now. Hopefully, listeners, you've enjoyed this episode and learned something from it, and we will see you next time.